So as we all know, Rituximab is a rather new entry to the armamentarium of nephrologists in managing various forms of nephrological problems. But the fact remains that Rituximab was first introduced into the pharmacology treatment for treatment of malignant proliferation of the B cells. This is because Rituximab is a monoclonal chimeric antibody targeting the CD20 B cells. And this was the reason why it was used in lymphoproliferative disorders and Hodgkin's lymphoma, where you get a malignant proliferation of the B cells, and people are looking for drugs which would specifically target the B cells and not the entire WBC population. And that's how Rituximab came into popularity. So mainly, initially it was used in Hodgkin's lymphoma, and subsequently it was then branched to various specialties, including rheumatoid, rheumatology. They use it frequently for rheumatoid arthritis, etc., hematological problems, and nephrologists have also decided that why not we use this drug. Now, Rituximab targets the CD20 antigen present in the B cell, and once it occupies that area, it results in complement activation and activation of the membrane activating complex, which results in destruction of the B cells, and that's how the B cell are targeted by this particular drug, which makes it quite attractive. So the question is, in nephrology, how does this drug which targets the B cell can be put to use? Now we know that several diseases in nephrology are actually antibody mediated. So it theoretically sounds quite good to target the B cells when you feel that it's antibody protection which is resulting in the various clinical features of renal disease. For example, in SLE, we all know that's B cell antibody protection. Similarly, in vasculitis, it's true. So this was the reason why we felt that this drug can be extrapolated to nephrological conditions where antibody protection is supposed to be a problem. But yet, still it can be used in diseases in which the B cells are theoretically not that much implicated in the pathogenesis. For example, in steroid-dependent nephrotic syndrome and frequently relapsing nephrotic syndrome, we were initially thought that this is a disease of the T cells. And when I was doing my DM way back in the early 1990s, if you did not say that nephrotic syndrome is a disorder of the T cells, you're sure to fail. But we have come a long way since then, and now we have realized it's not only the T cells, but probably the B cells may also be involved. Because this was, I think, suggested by the, as Sampath mentioned, the early 2000s when it was tried for steroid-dependent nephrotic syndrome and frequently relapsing nephrotic syndrome, and it was found to have dramatic effects. So this suggests that probably B cells may also be involved in this pathogens of nephrotic syndrome. Though there are some people who feel that it's not actually the B cells which is involved, this Rituximab is directly targeting the podocytes and thereby producing the remission. But other diseases like membranous nephropathy, where we come to realize that it's an antibody directed against a PLA2R, which is implicated in the pathogenesis. So here also theoretically B cell therapy could be of use. And vasculitis also because of antibody protection and SLE. These are also conditions where one would theoretically feel that B cell therapy would be useful. Now, renal transplant is again a different scenario. So what would be the role of Rituximab in renal transplant? ABO incompatible is one which will strike our mind because naturally we want to reduce the production of antibodies that is the blood group. And it has been initially tried in ABO transplantation following splenectomy, and people found it as an alternative to splenectomy. And they used it at the same dose used in lymphoproliferative disorders. That's 500 milligram probably every week for almost 4 weeks. This was the initial experience with Rituximab in ABO incompatible transplant, and then they decided that with Rituximab one need not really do a splenectomy and go ahead with ABO incompatible transplants. Now, antibody-mediated rejection is another vexing problem which nephrologists face, where the antibody is one which is producing the kidney, the graft damage. So here also Rituximab is used, and it's especially useful in the acute antibody-mediated rejection, though in the chronic it's not found to be that useful. Now, what does it have a role in the induction therapy? Now, the induction therapies are traditionally directed against T cells. You have got Rituximab, and you have got the anti-thymocyte globulin, etc., which predominantly targets the T cells. So, but we come to know that this cell-mediated rejection has come down. It's mainly the B cell rejection, antibody-mediated rejection, which is also not only producing long-term graft loss, but also early graft also is seen with antibody-mediated rejection. And there's a less, the incidence of cell-mediated rejection has definitely come down. So now there is a lot of feeling that probably induction therapy we should be including a B cell targeting therapy. So here also let us look at the role of the Rituximab has got a role as an induction therapy in renal transplantation. Now the question comes is, what is the dose and frequency which is appropriate? Now in lymphoproliferative disorders, the dose used was pretty steep dose, 375 milligram per meter squared, given every week for 4 doses. Now this, because this was the dose recommended in the pharmacopoeia based on the experience with Hodgkin's lymphoma, nephrologists decided that the same dose should be extrapolated to nephrology use. But is that the right thing to do? Because we know that nephrology conditions like SLE, lupus nephritis, membranous nephropathy, there's really no malignant proliferation of the B lymphocytes. So in that case, do we really require the same dose and frequency? Because here we have got only a normal B cell population. And the other important question is, shouldn't we be monitoring the rituximab dose as done with other drugs like cyclophosphamide? So we have been taught that before using cyclophosphamide, one should look at the total count. And unless the total count is 4,000 or at least more than 3,000, one should not give cyclophosphamide. And there are studies here suggesting that your dose of cyclophosphamide should be targeted based on the nadir total count at the end of 2 weeks. So suppose you are giving 750 milligram or 500 milligram of cyclophosphamide, and at the end of 2 weeks, your total count is 6,000, 7,000. That means your dose is probably inadequate. And on the other hand, if you are giving 500 milligram and at 2 weeks, your total count is less than 3,000, probably your dose was too much. So this was the traditional method of monitoring cyclophosphamide. And why is this not recommended for rituximab? That was the question which I was always worried. And I was always thinking of why we should be, because we have got a method to monitor the rituximab. So why this recommendation is not there? Why people are not recommending monitoring the CD19 or CD20 count and then targeting your rituximab dosage? That as Sampath mentioned, there are some side effects of rituximab. Generally, it's well tolerated. The most common is a drip reaction and allergic reaction is not much of a problem, but generally you have to give hydrocortisone, Avil, and probably paracetamol before starting the drug. But generally, most of these are very mild and not matter of concern. Infections, rituximab is supposed to produce a subsequent, depletion of the B cells, and so they are prone for infections because of less of antibody protection. People get reactivation of hepatitis B. And now there is a feeling that in COVID era, rituximab may have a problem because one thing is, if you get once a COVID vaccine comes, they may not develop an adequate immune response because the B cells are suppressed. And also whether it produces a permanent COVID infection, there was a initial fear, but now the most feeling is that mainly a T cell depletion produces COVID flare up, because we know that thymocyte globulins and mycophenolate are the one drugs which produce a flare of COVID. So B cell is not supposed to theoretically at least produce a COVID infection, but however, whether it will affect the vaccine response is a matter of concern. The more worrying problem of rituximab side is that it can rarely produce progressive multifocal leukoencephalopathy. And what is worrying about giving further doses of rituximab is that some of them can develop rituximab antibodies. So a second or third dose may not be effective. So all this makes it all the more important to decide to use the minimal dose and lesser frequency of rituximab, especially to prevent anti-rituximab antibodies and long-term B cell suppression. Now we have got methods to monitor rituximab. Even though rituximab targets the CD20 is generally seen in the mature B cells. The early forms of B cells and the plasma cells do not contain CD20. You have mainly CD19, so that's why people are now relying more on CD19. When you do ask for the laboratory CD19 count, actually you get a bit confused because they ask you, do you want total, do you want percentage, do you want absolute? So we are a bit confused. So for the benefit of the PGs, let us just discuss what is this total percentage, what is this absolute CD19 count. Now, if you actually look at the B cells, they are the lymphocyte, leukocyte. The total leukocyte count is approximately 4,000 to 11,000 is normal leukocyte count, but this includes polymorphs, etc. And lymphocytes, if you look, the absolute lymphocyte count is only a small percentage of the total leukocyte count. So it comes to approximately 990 to 3,000 cells per microliter compared to the total leukocyte count. So the lymphocyte count is definitely much less than the total leukocyte count because we're excluding the neutrophils, eosinophils, etc. Now, of these lymphocytes, the majority are T lymphocytes. So if you look at the B cells, of this 990 to 3,150, only a small percentage is actually B cells. Comes to only around 99 to 527. So when you ask for an absolute B cell count, you'll be getting a value like this, and from this we can decide whether B cell is suppressed or not. What is more reliable than the absolute CD count is to look at the B cell percentage. The B cell percentage would be the absolute CD count divided by the absolute lymphocyte count, and will give you a percentage. So, for example, if you divide 99 by 990, you'll probably be getting the value like this, 6 to 22. And this particular patient had a absolute CD of 172, whereas the absolute lymphocyte count was 5,500. If you look at calculate the percentage, it's actually calculated value. The total B cell percentage will be only around 3%. So this is what is the laboratory measures as a CD percentage. So this is important because when you are monitoring the rituximab. Now, this monitoring of this CD9 count is important for whether to decide on initial dose and subsequent dose. Like as I was mentioning, cyclophosphamide, we have been deciding whether the total count is more than 4,000, then giving a cyclophosphamide, and this total count is less than between 3,000 and 4,000, probably giving a lesser dose. So that's the same thing hold true with rituximab. Generally, people do not monitor the CD19 count before giving rituximab. But I think now, because the CD9 count can be done relatively cheap, only cost around 3,000 rupees. So probably one can look at the CD9 count and decide on an initial dose, whether it should be a high dose or low dose. But more importantly, it would be to give a subsequent dose, because if your CD19 cells remain suppressed, then the theoretically at least doesn't sound at all logical to give a subsequent high dose, especially if the CD9 counts are suppressed. So this is the main role for targeting your rituximab therapy based on CD19 counts. Now, I think we have to salute these authors, Remusi, Rugenti, etc., from Italy. And way back in 2007, see, it's 2007, they themselves looked at this method of titrating rituximab to circulating B cells. At that time, they looked at CD20 B cells. And they decided, why not we look at CD20 B cells and decide on titrating? And they compared it with a standard protocol of 4 weekly doses. And they found that once they monitored the CD20 B cells, they found that only one patient needed a second dose, which is a really amazing result. And they found that the costs could be brought down to as much as 10,000 euros to 13,000 euros savings per patient, which is really remarkable. So their conclusion was that avoiding unnecessary exposure to rituximab is extremely cost saving and may limit the production of anti-chimeric antibodies, which is the thing which I was mentioning. Now, this was published in a reputed journal, CJAS, in 2007, but unfortunately, I feel that it was swept under the carpet and nobody gave any importance to this article, because they've got several mega trials and key clinical trials on rituximab, and all of them have used the same dose which we have been using in lymphoproliferative disorders, and nobody gave any heed to Rugenti's and Remusi's landmark article. So I've got the RAVE study in vasculitis, which Ilangon will be highlighting on, the Rituximab, the Mentor study, which is again a key clinical study in membranous nephropathy, the Gemrutux, all these have used the same dose which they use in lymphoproliferative, a high dose, and repeated doses. They give it very frequently, weekly, for almost 4 doses, and without any monitor of CD9 count, it doesn't at all sound any bit logical as far as I am concerned. So these are the clinical trials reported in a reputed journal like New England Medical Journal of Medicine, used the same dose and gave rituximab without any monitoring and found significant remission, which is, of course, the question is, had they monitored and given a lesser dose and less frequency, would it we also have been able to manage this amount of remission with a lesser dose and lesser frequency? This is the thing which I think future trials should be looking at. Now, this is the Mentor trial. Everybody describes the Mentor trial, but look at the dose of rituximab they used. 1,000 milligrams. That's 1 gram, 2 doses apart at 14 days interval. Now, is this really justified? They also never monitored the CD19 count. Now, let us look at our experience. I think we felt that with the facility to do CD9 count and the cost also relatively less, so we can do it for 2,000, 3,000 rupees. And when pharma companies said that rituximab is available, it's 500 milligram, which costs 30,000 rupees, and you've got 100 milligram, which costs 6,000 rupees, and Trivandrum Medical College handles very economically backward patients. So the question is, shall we try 100 mg and shall we monitor it with CD19 count to see whether your dose is adequate, or are we not justified at all using 100 milligram, and should we be really using the high dose recommended in lymphoproliferative disorders? So this was the study, this was the thought which we felt, and we considered why don't we try with monitoring CD19 count. So we looked at 42 adult patients. They included 30 steroid dependent and frequently relapsing nephrotic syndrome, 5 patients with membranous nephropathy, and 7 kidney transplant patients who are at high immunological risk. So prior to, as an induction therapy, we used it in 7 patients, and we just gave 100 mg rituximab. And we gave rituximab after monitoring CD9 count and looked at the CD9 count after 30 days. And we found that almost 95% of them had CD19 count less than 1%, which is significantly low. So the question is, are we really justified in giving a subsequent dose of rituximab with 100 mg is produced total suppression at 30 days, and by 90 days, almost 50% remain suppressed, and they almost 6 months later, almost 1/5 of the patients still had CD19 count below 1%. So look at this 1/5 of this population. We would have unnecessarily been giving them high dose of rituximab 500 mg every frequently. We could remind the cost of rituximab 30,000 rupees given for every weekly for 4 doses. Was it really justified? Because just 100 mg is produced in 20% of the patients, even up to 6 months total suppression of the CD19 less than 1%. So in our study, we included steroid-dependent nephrotic syndrome, almost 27%, 7 frequently relapsing nephrotic syndrome, 5 membranous nephropathy, and 7 high immunological risk renal transplant. We used just 100 milligram rituximab after we checked the CD9. So we checked the CD9 count just prior to rituximab, and after 30 days, we monitored the CD9 count on 30 days, 90 days, 6 months, and 1 year. And we decided we will give further doses if the counts were, there's a replenishing of the B cell CD9 count, and again, depending on clinical response. Like suppose the person had a relapse and the CD9 count still was low, we probably would have decided on giving a subsequent dose. And we targeted the CD19 count to be suppressed if it was less than 1%. As total percentage of CD9 count less than 1%, we said it's suppressed, and more than 1%, probably you would consider a second dose depending on the clinical response. Now let us look at our observation. You see that at day 30, you find that almost 93% had total suppression of the B cells, and 96% of them went into complete remission. By 3rd month, you find that almost some of them, 2/3 of them had replenishment of the B cells, but still in almost 1/3, it was still suppressed at less than 1% at 90 days, and almost 96% of them were in remission. And by day 180, again, the CD percentage count, there was a replenishment, but still 76% of them continued to be in remission. So this is again suggesting that lesser dose of rituximab and lesser frequency may be sufficient in frequently relapsing nephrotic syndrome, probably provided you monitor the CD9 count and clinical response. Now, of the 27 steroid-dependent and 3 frequently relapsing nephrotic syndrome, 100 mg of rituximab was given. At day 30, you find that almost 28 out of 30 had total suppression of the B cells. Of this, 1% received an additional dose because he failed to respond. 1% who did not respond again received an additional dose. And by day 30, 29 were in remission. And by day 180, 23 out of 29 maintained remission, and 6 patients relapsed and these patients received an additional dose. So we find that at the end of 1 year, 2 patients relapsed, so we gave an additional dose again to these patients. So none of these patients required more than 2 doses of rituximab in steroid-dependent nephrotic syndrome. So that is again a significant economical advantage. Now this, our observations were again replicated in another study, again present in JASN. And they found that 1 dose or 2 doses of rituximab 375 milligram, and at 11 years, all patients were in remission, 18 were treatment free, and 15 never relapsed. Again, suggesting that using every week for 4 doses doesn't sound at all logical, and definitely it will drain your money without any benefit and possibly increase side effects as well. Similar observations again reported by a Japanese group where they found that a semi-annual, they used semi-annual 100 mg rituximab, and they found that semi-annual with a single fixed rituximab dose of 100 mg, complete remission was obtained in 3 cases. So I agree it's a small number. So now what is the observation in membranous nephropathy? See, in membranous nephropathy, again, we used it in 5 patients. At day 30, almost 100% of them had CD cell suppression. And by day 90, 50%, 1/5, 20% had suppression of the B cells. But if you look at the clinical response, you find that almost 80% of them went into remission. But at day 180, again in remission, partial or complete, but 1% actually failed to respond, and he failed to respond to a high. We thought that since he failed to respond to 100 mg, should we not be giving 500 mg? But we gave 500 mg and he still failed to respond. So this suggests that probably this person may be in remission. So a person who is not responding to 100 mg may not respond to 500 mg. And probably a person who is responding to 500 mg would probably may have responded to 100 mg. So this is something which has to be looked into, but we have got only 5 patients. So the argument is that probably these 5 patients were the group which would probably have responded early and the better prognosis. So we require more patients before we can make a definite recommendation. And we feel that 100 mg rituximab in membranous nephropathy of 5 patients, 4 achieved remission by 6 months, which is sustained in 3 by 1 year. Again, suggesting low dose may be sufficient. And this was again substantiated by the Italian group, where they again found that single or 2 doses is still effective in membranous nephropathy. One need not be giving high dose. And this observation was also replicated by the PGI group. Raja Ramachandran, they used 100 mg of rituximab, and 3% achieved complete remission with proteinuria normalized and serum albumin. And mean time for replication of B cells was approximately 2 months, again suggesting 100 mg may be sufficient in membranous nephropathy. What about renal transplantation? Renal transplantation, we used it in 7 high-risk renal transplantation patients, and we found that in such patients, the CD cell was suppressed for almost a year. Just 100 mg was sufficient to produce a total B cell suppression. So suggesting that 100 mg may be sufficient, and again using 500 mg in renal transplant may not be required. Compared to membranous nephropathy and steroid-resistant, steroid-dependent nephrotic syndrome, the CD cell suppression may be more in renal transplant, probably because they were using other immunosuppressive drugs which are suppressing the bone marrow. This may be one explanation. So, ladies and gentlemen, we feel that 100 mg rituximab may be sufficient, provided you monitor the CD9 count and depending on the response. And probably membranous nephropathy, we agree the number of patients were less, but probably one could try with 100 mg, and if they fail to respond, go for a higher dose if warranted. So, thank you, and I'm happy to hear the experience of others in this field as well.